We shall now go on to our next speaker, Dr. Soundarya, who is a consultant at the Eye Foundation Group of Hospital based at Coimbatore, and again a consultant in cataract, cornea and refractive surgery, a very dynamic young ophthalmologist, and I see a great future for her. And she is going to be dealing on topo-guided treatment, a major aid in visual rehabilitation. On to you.
Very good evening to all the respected panelists and speakers. I'm very thankful for Dr. Chitra ma'am for giving me this opportunity. So after this extensive discussion on cross-linking and the various indications for treatments in keratoconus, I would like to talk about a few points about the topography-guided treatment in keratoconus and how and why it works in visual rehabilitation in these patients. So as we all know, cross-linking prevents the disease progression, but the patients are still left with an irregular cornea, and that is filled with aberrations, and which thus decreases the visual quality. So that is where topography guided treatment comes into play. The idea of topography guided treatment is to transform the focal steep cone into a flatter, broader cone, thus creating a more uniform refractive surface. So this is achieved by creating a myopic ablation at the apex of the cone in the center, which causes a flattening, as we can see, and a mid-peripheral arcuate hyperopic treatment, which helps in steepening the flat cornea anterior to it. So what are the preoperative requisites? As it has been told, a minimum preoperative corneal thickness of about 450 microns is required, or in other words, an intraoperative residual stromal bed following ablation and epithelial removal of 350 microns, or a postoperative thickness following the reepithelialization of 400 microns. So does it mean that in any patient with less than 450, we cannot go ahead with topography guided treatment? No, we can go ahead, but we need to keep in mind that the postoperative thickness does not go below the recommended level of 400 microns. And the ideal candidates are those with mild to moderate keratoconus. And coming to timing of procedure, definitely when combined with the topography guided treatment, the simultaneous procedure does have advantages over sequential procedures. One is the reduced time away from work for the patient, of course. And the second point is the possible reduction of haze that follows when combining it with topo guided PRK, because cross-linking induces a keratocyte apoptosis, which thus reduces the number of migrating fibroblasts, which are the main reason for the haze. And also it helps in enhanced penetration of the riboflavin into the stroma. And as has been told, the conventional versus accelerated CXL, that is a 9 milliwatts per 10-minute protocol, has shown to cause a lesser amount of haze and a lesser flattening effect. And when it comes to keratoconic eyes, we know that there is a variable epithelial thickness that is thinner over the apex and thicker over the base. So in manual debridement, we're going to be variably removing the epithelium. So the final surface that we're going to be treating is going to look quite different from the surface that we have preoperatively measured. But in PTK, when we're doing a phototherapeutic keratectomy, there's going to be a uniform tissue removal throughout, which is going to result in a surface which is going to mimic more closely the surface that we have measured using the topalizer preoperatively. And when coming to planning, here we need to remember that the idea of a topo-guided treatment is not a refractive error correction, but it's just for the regularization of the cornea. So here we tend to bring down our optic zone to 6 mm or sometimes even 5.5 mm in order to save tissue. And the maximum amount of tissue ablated, we try to keep it below 50 microns, but there have been studies which have gone up to 80 microns, and provided that a good amount of tissue is available. And a minimum of 6 repeatable good scans are required to proceed with the planning. Just a few words regarding the steps of planning. This will be the first screen that we'll see. So the exported scans from the topalizer are seen here. And what we need to note here is the mean deviation has to be kept within 0.1. That means the scans have to be more similar to each other. So when the mean deviation values are higher, we tend to go and remove any outlying scans so that the final value of mean deviation comes below 0.1. Once this is done, the next step is to enter the manifest refraction along with the pupillary diameter and the corneal thickness in the center and the 6 mm zones. First, by making the modified refraction as 0, what we're going to be seeing is the basic ablation profile that the machine is going to be doing in order to regularize the cornea. So as we have told, the myopic and the arcuate hyperopic ablations that are going to be done. And we're going to be noting the amount of tissue that is being utilized for the same. So here we can compare this with the axial sagittal curvature map of the pentacam, where we can see the steepest area, there's a myopic ablation, and the mid-peripheral arcuate ablation is also going to be noted. So after we note the amount of tissue that is used for regularization, then we can plan for the refractive error debulking if the tissue is available. So here first we're going to maximally debulk the cylinder as much as possible, following which we can go ahead and correct the refractive sphere. So when we're correcting the refractive sphere, we need to remember that we're going to be undercorrecting the refractive sphere in order to compensate for the flattening effect of the cross-linking. Although accelerated cross-linking has shown to cause a lesser flattening effect, we tend to undercorrect the sphere at least by a 0.5 diopters. So here, this is one of the simplest cases to plan because the refractive cylinder, the magnitude as well as the axis are correlating well with the manifest refraction of the patient. So here we can go ahead and plan as given. However, in more irregular corneas, we tend to see that the measured cylinder is going to be quite higher, and as well as the axis is going to be quite different. So in these cases, unlike the contour planning that we do for a refractive correction, here we tend to go more towards the topographic axis as well as the magnitude of the cylinder, because the idea is to regularize the anterior surface of the cornea. So if the refractive cylinder of the topography is higher, we tend to go correct higher than the manifest refraction as well, and also with the axis. So to confirm the axis, we can also compare it with the front elevation map of the pentacam. As we can see here, both these maps correlate well. And here another point to be noted is that we've gone down with the optic zone in order to reduce the tissues consumption. It's the example showing the outcome. So we can see that the topography has regularized quite well, and the uncorrected as well as the best corrected visual acuity have increased, and there is quite a significant amount of debulking with both sphere and cylinder. So just two maps that I wanted to show where we need to be a little more careful in planning are these maps where there is a significant amount of asymmetry, extreme asymmetry around 10 diopters, and there is a flat K reading in the center. So in these kind of patients, as we can see, the arcuate hyperopic correction is going to steepen the flat area that is seen centrally. What this will result in is a myopic shift for the patient. So in the patient had just a 0.5 hyperopic correction has resulted in a minus 3.25 diopter sphere. So although the visual quality or the BCVA improves in such patients, the uncorrected visual acuity may not, and we need to explain this, and this shows the importance of the need for patient counseling preoperatively, and to explain to them that what we're doing is not for a spectacle-free vision, it's just for improving the quality of vision. Another tissue-saving measure is adding a hyperopic error when the patient actually accepts a hyperopic error. So as we can see here, when we're not adding the +1, the tissue consumption is around 59 microns. Whereas when we go ahead and add the +1, it reduces to 51 microns. So comparing between centered and decentered cones, the effect of final visual outcome has been shown to be good. However, the uncorrected distance visual acuity has been found to be better with centered cones. Just an example of a centered cone where the BCVA was 6.9 with a 3.75 cylinder, which improved to 6.6 with just a 0.5 diopter cylinder, and you can see a beautiful regularization in the topography. And a decentered cone here, we can see the more than 50% of the points lying outside the 3 mm zone in the back elevation map. With a BCVA of 6.9 and a 3 diopter cylinder, patient ended up with a plano 6.6 vision. Use of mitomycin C, as has been discussed, has conflicting views because Quinones et al. Had shown favorable outcomes even without mitomycin C. However, we still continue using intraoperative 0.02% mitomycin C for about 20 to 40 seconds. And stability, Kanellopoulos et al. Have studied the 10-year outcomes of keratometric and visual stability, and they've shown that only 3.5% of the eyes have shown progressive flattening or a hyperopic shift. Another new arena that can be that has shown early good results is the customized cross-linking combined with topography-guided treatment. The other uses of topography-guided treatment in other irregular corneas like PMDs and iatrogenic classic ectasias have also been good. And in other cases like decentered ablation, small optic zones, and post-PK and RK eyes, also topography-guided treatment can be used. Just an example of a post-classic ectasia with a highly irregular cornea, as we can see. So there's a beautiful regularization, and the patient's BCVA and UCVA have improved quite well. So when combined with cross-linking, apart from arresting the progression, topography-guided treatment definitely aids in patients, especially with early keratoconus, early to moderate keratoconus, to give them some degree of spectacle independence, as well as improving the visual quality and the best corrected spectacal visual quality in these patients. Thank you.
Yes, that was a wonderful talk, Soundarya. So I'm going to ask this question to you because I know how intensely involved you're in the planning of these cases. how would you deal with a hyperopic shift following a topo-guided PRK? Would you give us some tips how to prevent it?
Ma'am, initially to prevent it, basically the planning has to be done well, ma'am. So main idea is as I've told, when we debulking the cylinder, we need to keep in mind that we're not going beyond the spherical equivalent or the refractive spherical equivalent of the patient. So if we're going to be overcorrecting it, definitely a hyperopic shift can be expected in such patients, ma'am. So that is something that we need to keep in mind.
Or sometimes if it is haze which is causing all these issues, sometimes
and the long-term steroids can also be given.
Yeah. And one controversial question before I ask Radhika, what are your thoughts of topo-guided PRK in pediatric KC? I did hear what Sahil had said. Would there be a small segment where you would consider doing a topo-guided PRK in pediatric KC? And who are the other people on the expert panel who are doing topo-guided PRK? Dr. Namrata?
Yeah, Chitra, I think it was a very nice talk. It is a difficult topic.
Yes.
Not very many people venture it. Not very many people are convinced about it. But I think Soundarya showed very good pictures, to actually, which can convince people that it does work and we should do it. In children, we've not tried to do it, and hyperopic shift is a reality, and I'm glad that you brought that out. I don't know how it will work out in children, because everything tends to be a little more unpredictable, and we've not done in any children. I don't know if you have done any, and if anybody else has done and would like to share the views on the same.
Yeah, no, I was just wondering whether in a younger age group, when there is a compromised BCVA and there's a possibility of amblyopia getting more, would that be an option when you could do a small amount of regularization of the topography with cross-linking? Anybody on the expert panel have something to add about this, or it would remain a question?
Can I add something?
Yes, Dr. Praveen.
So, I think, like we discussed in the previous talk, and we were speaking about how children are more likely to require repeat cross-linking than adults.
Yeah.
And also because the time to potential progression is longer. Like say, if you're doing cross-linking for a child, and you're likely to be requiring a second cross-linking, I think from that perspective, it is important to avoid doing a PRK in anybody who might require a repeat cross-linking, at least from that perspective.
Yes, agree. Yes, definitely an answer. So anything else, Dr. Radhika, would you like to ask?
Yeah, so as a continuation to the answer that Dr. Praveen gave, I have another question for him or the others, that if you did a TG-PRK, we know that we've well established among ourselves now that there could be progression after cross-linking, especially in the younger age group. So if progression did happen after TG-PRK, then would the indicators be the same or different that we use for conventional, non-topography guided cross-linking? How would you pick up progression after TG-PRK?
So Radhika always, makes us think more, and I completely agree with this. I never thought that this would be, the parameters would need to be different, but I think you are quite right. The parameters for virgin corneas and for TG-PRK corneas of keratoconus would possibly need to be different, and maybe you would also need different devices for them. Even for repeat cross-linking in children, when you say we are actually only based on Schemflug or Pentacam, but I think you would need something like a MS39, because after collagen cross-linking, there's a little bit of haze, which the Pentacam gets fooled by, but MS39 will not get fooled by. So I think these are issues which will remain and which would need to be sorted out.
Also, I would feel that in that case, a holistic perspective of, the history, the patient's vision with contact lens, subjectively what the patient feels, everything put together along with the imaging, and like Dr. Namrata rightly said, what's happening below the epithelium at the Bowman's level with an imaging device would give a better clue as to whether the disease is stable or not once we've surgically. Thank you.
Yes.